Good morning, everyone, and welcome to this second webinar in our series. Last week, we heard from Catherine about catastrophic expenditures in health and their impoverishing effects. And today, we are very honored to have Dave Gwatkin with us. And Dave will provide, give a presentation on how to assess whether PBF intervention is pro-poor, is reaching the poor. The presentation will be in English, but we will take questions in both English and French. And after the presentation, we'll have enough time to go over the questions and to have a discussion. And whenever a question has been asked in French, we'll try to translate Dave's response to French as well. So I'll leave it to this, and I'll give a few words in French for our francophone participants. Bonjour à tous et bienvenue à cette deuxième session dans notre série de webinaires. La semaine passée, nous avons eu le plaisir d'avoir Catherine Coracher avec nous, qui nous a fait un exposé sur les dépenses catastrophiques dans la santé. Cette semaine, c'est Dave Gwatkin que nous accueillons et qui va nous faire une présentation sur comment savoir si notre intervention atteint les plus démunis. La présentation sera donnée en anglais, mais après la présentation, il y aura suffisamment de temps pour des questions et des réponses. Et ceux qui préfèrent poser leurs questions en français peuvent le faire. Et on fera notre possible pour traduire la réponse de Dave en français également. À présent, je vais laisser la parole à Dave.
Il faut m'excuser pour ne pas vous adresser en français. Malheureusement, mon français est tellement mauvais que je crois que même le francophone peut mieux comprendre anglais. Et pour ça, je vais parler en anglais. Je m'excuse. Now, this is our topic for today, the question of how health programs, how we can tell whether PBF health programs are reaching the poor. It's often assumed that PBF programs are inherently pro-poor, but that's not the case. In fact, there are reasons to think the opposite might be the case, at least a priori. First, if you provide, provide incentives to providers, the providers have an incentive to find the people who are easiest to attract as many people as possible, and it would make sense if they were to go first to those who are easiest to reach, who are closest to them, and these are likely to be the better off. If it's demand-side incentives, there's always the likelihood, or possibility at least, that those who will learn about it first will be the better off and will take disproportionate advantage. There's a well-known case in Nepal of incentives for attended deliveries where the vouchers were distributed at clinics, so it was only women who came to the clinics who knew about it, and those tended to be better off women. Now, my presentation will be in 4 parts. That's the arrow. Sorry. This one. Oh, that arrow. Okay. All right. How can we tell if programs are reaching the poor? I want to, in 4 parts. First, a somewhat conceptual or theoretical presentation of a suggested approach, the basic features. And second, some case studies of health programs that illustrate how this approach could be applied. And these are not the PBF case studies. And then a third section on how the approach can be adapted to assess PBF programs. And then fourth and finally, a discussion of limitations. Now, part 1, the suggested approach and the basic features. What is it that we desire, and what kind of information do we want to have? What kind of data do we need to get that kind of output information? And then how do we tabulate data? Those are the 3 subtopics. Now, On the question of what we want in the way of information, what we want is simply a comparison of the socioeconomic status of two groups. The first group were the group of people who receive program services, and the second group will be the socioeconomic status of the population as a whole, at large. I'm referring to socioeconomic status here as an example, particularly economic status, but it can be any kind of social status. It can be gender, it can be ethnic groups, and so forth. I'm referring to the population at large as the comparative population. Sometimes it's done as the population not receiving services, but I'm going to say the population as a whole. And this comparison can be expressed in many different ways. One would be, and the easiest, would be average socioeconomic status of the two groups. And a more common one, distribution of socioeconomic status across economic groups. Now let me explain what I mean by each, starting with the average socioeconomic status, because that's the easier. Now let's suppose we have three groups of people served by different programs, A, B, and C, and each of them have the same economic status. Let's say an income, and let's say it's $5,000 a year. It can be francs, it can be per month, it can be income, it can be expenditure, it can be wealth. Let's for the moment assume an income of $5,000 a year. That's the population as a whole. Now, if we find out that the population being served by the program, if their average income is $5,000 a year, then we say that it's equally distributed. It's the group beneficiaries are the same, have the same income as the population in which the services are offered. But suppose there's only $2,500 a year, the program beneficiaries, then you say it's pro-poor, because the average income of these people is much below the average of the population. On the other hand, if it's $7,500 a year, the income of the program beneficiaries, then it's pro-rich, because the people served have an average income considerably higher than the population as a whole that it's seeking to serve. Now that's one method, that's the average. That's not used very much. What's used more commonly, and what I'll be using, is a somewhat more sophisticated approach that has to do with the distribution of beneficiaries across economic groups. Now let's say we divide the population into 5 groups or quintiles from low to high, and let's suppose that the 20% of the program beneficiaries are in the poorest 20% of the population, and 20% of the beneficiaries are in each higher group of the population. Then we would say that the program is equitable, or at least providing equal services, because the proportion of total service recipients is the same as the proportion of the population. 20% of the services going to the poorest 20%, 20% of the service going to the highest 20%. In other words, these columns always add up to 100%. It's the percentage of total program recipients. Now this is an equal outcome illustration. Here is a pro-poor illustration in which about 25 or 27 or 28% of the beneficiaries are in the lowest 20%, and only about 10 or 12%, 11, 12% are in the top 20%, economic 20% of the population. Now, on the other hand, you can be favoring the least poor, not the last poor, the least poor, and which is more typically the case, in which the bar for the least poor is higher than the bar for the poorest. Or, unfortunately, sometimes you get very ambiguous figures where the different quintiles, the rates go all over the place, and it's really not so easy to tell. You can on balance, but it's a bit ambiguous. Now, how can you get this kind of output information? What kind of data do you need? You need economic information about 2 groups, One is the population at large, that is the target population that you're trying to serve, the total population of a country or of a state or of a province. And the comparable data, and I stress the word comparable here, about the economic status of members of people who the program actually does serve. For the socioeconomic status of the population as a whole, you have to have household level information, collected either through a survey or a census. The data about economic status of the people service recipients can be collected through a wide range of methods, a survey, a facility survey, or service records, as we shall see. Now, how do you tabulate this data? It really depends on the sources of data available, and it's easiest to explain with reference to specific examples or case studies. So let's proceed to part 2, which provides 3 case studies. Now, one will be the social marketing of condoms in Ghana, a national program; Kenya, an immunization program, campaign, a national program; in Bangladesh, patients at government health centers in 2 large districts. Now, Ghana. It's a nationwide program that sells subsidized condoms through drugstores or pharmacies. And you have 2 types of data about the population as a whole. You have a pre-existing national household survey, the demographic and health survey, that has information about household wealth or assets. Now, to get the information about the economic status of the population served, the study conducted a survey of retail outlet customers with a questionnaire that containing the same household asset questions in the DHS, in the national survey. Now, let me explain that a bit, dwell on this for a bit to explain the asset approach. The Demographic and Health Survey is a well-established international program. I'm sure there's one in almost all countries, probably in all of your countries. It is primarily oriented toward getting things like birth rate, death rate, service use. But their survey instruments includes a series of questions about household possessions or household assets. Possessions like a radio, refrigerator, car, bicycle, etc., whether they own land, and if so, how much, where they get their drinking water, the type of toilet, the type of flooring, and the number of people per sleeping room. And this gives you, by putting these together in an index, you can get an estimation of household assets or household wealth.